Welcome to the Interventional Glaucoma Podcast, brought to you by Elios. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field.
Thanks very much for joining us here again on this episode of the Interventional Glaucoma Podcast. Today we've got Marc Töteberg-Harms and Hamann from Iowa and Zurich respectively, and we're going to be talking about the health economics of glaucoma generally, but specifically the health economics of interventional glaucoma. So what I'd like to do is to kick off with a discussion about the terminology in health economics, and then move on to some of the specific concepts and how they really apply to minimally invasive glaucoma surgery, or MIGS, and what that may mean for introducing MIGS to our practices, and also perhaps even a wider justification of the use of MIGS in the general healthcare services that we're all part of. So let's dive into those questions. Well, to both of you really, choose who you like. Well, maybe Marc, you go first. For those not familiar with the health economics terms, or even the general concepts of health economics, how would you describe it to them? How would you describe it to somebody who wasn't within in medicine about what we're discussing today?
Yeah, we always have to face that we have a limited supply and demand, and on the other hand, we want to allocate our resources effectively to our patients fairly. And that's what kind of health economics is looking at. So you want to be allocating your resources, your treatments, considering that what you do is cost effective.
Okay, so cost effectiveness means we're applying a cost to a particular intervention or a pathway of treatment, and also at the same time having some form of metric of the success of that outcome, I guess. So you've got the two components trading off against each other. You've got the cost and the effectiveness. What would be the metrics that you would be commonly using within a health economics environment to measure that sort of success? We're all familiar with how to measure cost, but what would you be measuring for the effectiveness part of this?
Well, in glaucoma, we usually look like, hey, and treatment lowers your pressure, your IOP goes down. So you look at IOP lowering, you look at how long it lasts. So you want to have a treatment that lowers the pressure, but also not like the effect is fading out after a year already. That would be likely not a sufficient treatment for a chronic disease where we face patients with a lifespan still in the 20, 30 years nowadays. So you want to have a long-lasting effect to preserve their vision. So there are different factors that you can consider in what is actually effective, and it's actually something we have to define often.
So those are effectiveness of the success of treatments that we're familiar with. What are the sort of broader metrics? I've heard of QALYs and DALYs, and most of our audience will, I'm sure. We've got quality adjusted life years, we've got disability adjusted life years. Would either of you, I don't know whether it's Timothy or Marc, would either of you like to have a stab at trying to succinctly describe what that should mean to us?
Yeah, I think it's a new bit of vocabulary for many of us. So there is words or compositions that are named ICER, for instance, that's incremental cost effectiveness ratio. Mm-hmm. That's a metric that compares additional cost of an intervention, be it MIGS or any other type of surgery, to the additional health outcome. And that's typically measured in, you already mentioned, QALYs. So that's quality adjusted life years. And that's a metric in health economics that's measuring the value of a health outcome. And quality adjusted life years is usually used in determining whether a new intervention is cost effective. And in order to give that some real life connection, there is another interesting term, which is willingness to pay threshold. And that's a term that says, gives information about the willingness of an individual or a society which is willing to pay for a unit of healthcare benefit, which is typically measured in QALYs, so in quality adjusted life years. And that can be measured by a threshold. In the US, that's typically $50,000. And that apparently is based on a calculation for dialysis in renal failure, which gives a certain level of QALY, and that cost is thresholded by $50,000. So this is some of the new vocabulary within health economics.
So presumably the willingness to pay threshold is a society-defined willingness to pay for a particular cost, and it depends on how much money there is in the system and the trade-offs, and one imagines that it might be different in a developing nation from a more affluent industrialized country.
Yes, absolutely. And this is also where health economics distinguishes between, for instance, first world countries who can afford far higher willingness to pay threshold than countries with, less money in the system.
Yes. I mean, I think here in the UK, I mean, I would have to go and check that this is still correct, but I believe that we generally work at a £20,000 or £30,000 per QALY willingness to pay threshold, and the reason there are two values is there is a different value for sort of end of life care from that is for chronic disease, and there are some people who debate whether that's appropriate or not, but I think that's the correct value. I mean, Mark and Tim, both of you, would you like to comment, perhaps Mark first, on how this might apply to bringing new technologies and innovation into our departments, and some of the barriers that you've faced with this? Does being able to handle this sort of discussion confidently help you with those introductions of new treatments?
It actually does. I mean, if you think about like how enthusiastic we always are when we get something new, and then on a second page we look at like how much does it actually cost. Like if we don't have to look at the cost factor at all, we will say like, well, that's an amazing treatment that works. But then suddenly, if something new is being introduced, it's maybe very, very expensive, and that makes it limited to be used in practice. If patients will pay out of pocket, I mean, you have to tell them like, hey, that's the cost factor. That's what you can expect from a treatment. If a health insurance system is involved, it's getting even more, and that's where this all comes into account. They look obviously like, hey, does it actually work? And what do we have to pay for that? And from a patient perspective, going back to this QALYs, I mean, ideally, everything would increase the quality of life to perfect, to a 1.0 value, and not to completely imperfect, to a 0 value. But I mean, reality is somewhere in between. And as you said, like depending on how much financial resources a country has, we have to allocate the money to fairly treat all our patients and all different diseases. And yes, in real life, we look at these values, maybe not the real numbers, but we have that kind of in mind when we think about what we do and what we want to offer.
Do you think it's getting harder to introduce innovations because particularly in our sphere of glaucoma and interventional glaucoma, minimally invasive glaucoma surgeries, do you think it's getting harder because it's such a crowded market? Do you think we need to have a clear benefits, whether those are financial or clinical, over existing treatments?
I feel it's getting more difficult, yes. I mean, in the past, we did our trabeculectomies, and they were pretty cost effective. I mean, you didn't need much equipment. You needed a couple sutures, and you needed your operating time in the surgical theater. But otherwise, the costs are very low compared to the new procedures that have been introduced, where we have devices and implants, and we pay quite a lot for those. The problem is also, and that goes kind of hand in hand with innovation, innovation has kind of like spiked. So a lot has been introduced in the last years, and a lot has been used. And if you use a lot and treat patients, suddenly the total amount of cost that an insurance or healthcare system or government is looking at looks quite significant. And
yeah, I'd agree. And one of the difficulties that I foresee with these sorts of analyses is that often the incremental benefits of minimally invasive surgeries are, we think, prolonged and incremental over many years. You can take a cataract out and somebody's better a week later or even a day later. Whereas if you lower their intraocular pressure and get them off drops, they've got a lifelong reduction in their risk of glaucoma surgery, and there's evidence for trabecular bypass doing that successfully. And they've got a 5+ year scope for having less rapid visual field progression. And again, there's good evidence from randomized controlled trials of trabecular bypass being able to achieve that. But that's a much longer time window, isn't it? It's harder to get data on that and persuade payers of that. So I think one of our hurdles is that we've got these longer time frames that we see in glaucoma, particularly with the minimally invasive glaucoma surgeries. You don't get as much bang for your buck as quickly, even if you do get more bang for your buck in the long run, perhaps. Moving on, perhaps, I mean, there's been a lot of work done, I'm aware of, that looking at the cost effectiveness of MIGS, which I'm sure many of our listeners may not be fully aware of. What kinds of analyses have been done, and what are you aware of? What did they show?
Well, there has been a lot of work done, especially also in the North American sphere, in Canada. There's one very prominent glaucoma specialist. I think Ike Ahmed did plenty of cost analysis, cost effectiveness analysis for mixed procedures. And the findings showed cost effectiveness for many also trabecular meshwork based procedures. But Gus, you already mentioned that the thresholds, they vary within the different systems. And I think in the majority of those trials, the threshold was still defined as $50,000 per year. Whereas, as you just mentioned, in the UK, for instance, it's about 20 to 30,000. So, and the other point is that when does a procedure start to be cost effective? So with trabeculectomy, that's quite rapid. Whereas with the mixed procedures, if there is a prolonged effect, cost effectiveness can be achieved. But the question is, when does that cost effectiveness take place? And there is one more thing that I like to add about also the initiation of new treatments, or how there are burdens for new surgeries, for instance, because there is always room for disruptive treatments. And I think that everything that works will prevail, and that evidence is our best friend there. And I think you showed nicely with the SLT that sometimes it's just about creating a high quality study in order to show that something is effective. And if this means that it increases the quality of life and later on also demonstrates that it's cost effective, I think we still have a good chance to have new procedures. And we can still hope that innovation and also disruptive innovation will come along in ophthalmology. And as Marc laid out, I think the health economic factors and metrics can be helpful in that. Whether we have to introduce that to our studies as well, I do not know. But there is plenty of work, especially done in Northern America there already, for cost effectiveness analysis that might help us to design future trials.
Totally agree with what Timothy said. I mean, if you do a mixed procedure, you have upfront costs by doing additional procedures as a standalone, or if you do it in combination with cataract, which is a disadvantage. So in the beginning, you have to pay more money for that patient. But depending on the effectiveness of the procedure, how long it lasts, how effective it lowers the pressure, and how long the patient lives, you later may save money, for example, by having to use less drops. And again, you cannot generalize the data you get from one calculation for different countries, because the costs for surgery, but also the cost for medication vary quite significantly between the different health systems. But in general, if you think about like, hey, I have a procedure and it may last to reduce the pressure and the medication burden by 5 or 10 years even, you save some money for medications for 5 or 10 years. And that's the benefit you get later on from a procedure. And as a bottom line calculation, the upfront costs have to be less than the savings you have later on.
Yes, of course. I mean, I think it's a fascinating area of justification of what we do that's incredibly important as we're all competing for resources. Where I find the complexity comes is when you start realizing that if you're preserving visual field, then you're ultimately preventing blindness in a number of individuals. You're also probably preventing a number of falls, and we know that falls are costly to society and come at a cost for the individual. So it's wrapped up in a lot of complexity if you really drill down into the data. Speaking of which, I'd like to sort of try and drill down into some of the research, Marc, that you've been doing and that you've been over from the US to present at ESCRS. Can you tell us a little bit more about the analyses, the methodology, and the results of that research?
Absolutely. So what we actually have done is initially we did a meta-analysis of the data that's out there on excimer laser trabeculostomy, either as a standalone procedure or as a procedure combined with phaco. And from a lot of studies that have been there, we looked in like where we actually have data for 1 and 2 years for efficacy, but also for safety. And we came down to 17 studies that we could include in the meta-analysis. We looked, as I said, we looked first, is it effective? Does it lower pressure? How safe are the procedures? And as well as a standalone, as a combined procedure, it lowers the pressure effectively at 1 and 2 years. We also have data from longer studies, but those were not included in the meta-analysis because those are single publications. And we looked at safety, and safety was actually also quite good with a complication rate between 2 and 4% for standalone and combined. The rate of subsequent surgeries that we found was much lower in the combined procedure than the standalone, but that's kind of like what we know for most of the mixed procedures. So that was not a surprise. We went on and took all these data and went into a cost analysis, and we spoke about that. Like, you have to look at certain countries and certain health systems if you want to make a calculation if procedures are cost effective. So we picked 3 European markets, the UK, Germany, and Spain, for the cost analysis. And again, looked in excimer laser trabeculostomy or ELT alone and combined with phaco. And we saw that there are upfront costs for both procedures. They only varied in the countries quite significantly as well. But then we found, actually, when we looked long term, all these procedures, when they were done in the 3 country markets, they actually saved quality of life. They increased the qualities, and they were still cost effective over time. And that was quite impressive for me because, again, you mentioned that we always argue about that these mixed procedures, they are not so effective. So it's not such a pronounced effect that you get a patient in with like a super high pressure, you do your trabeculectomy and the pressure comes down to basically normal. These procedures are really like marginally lowering the pressure, but they can sustain and have a long-term effect, and they can save medication. That's what we found in the cost-effective analysis.
So I think one of the things that your analyses really bring out well is how variabilities between regions, environments, and different societies because of the different costs involved. But there seems to be very much a trend towards, and your research bears this out, that if it's cost effective in one, it's very likely to be cost effective in another, although the actual magnitude of those benefits may vary. I think I'd like to just move on to, aside from the cost effectiveness considerations, just thinking now more purely about the clinical aspects and the clinical benefits that you may be able to get with MIGS. Do you think now that there's a a duty to inform glaucoma patients about phaco MIGS when they're having cataract surgery? Do you think we have a moral or even legal obligation to do that in your environments? I can talk about the UK in a minute.
I think there is a parallel to be drawn to cataract surgery, where now we have a spectrum of implants available, and we are it in some countries it is already our duty to inform the patients about availability of different implants, and if you take that into account and want to mirror that to availability of MIGS, I think if you have MIGS procedures available that you could offer your patient, and if the patient fits the profile, and if by consideration of evidence it makes sense to use a MIGS procedure in this patient, I think you might very well say that as a glaucoma specialist, we have the duty to inform our patient about that option.
What about you, Marc? What was it like where you are in the States? I know that the States vary a lot between state to state in terms of law and remuneration and coding and all sorts of variation. But what's your impression of practice in the US? I think you've worked in a couple of different states in the US, if I'm correct.
Yep. I like the analogy that Timothy brought up to cataract surgery. I mean, it's the same procedure. When you think about like cataract surgery, you have a one in a lifetime chance to implant a certain intraocular lens at the end. The reimbursement system for the US is so that most of the MIGS procedures are only approved and reimbursed in combination with cataract surgery. And that's where it comes like, hey, now it becomes parallel to the cataract idea. If you do a cataract surgery in a patient who has a co-diagnosis of glaucoma, and those are about 20 to 25% of the patients who underwent cataract surgery in the past, you actually only have a once in a lifetime chance for them to offer them a MIGS procedure. And what you said is, for me, true. Meanwhile, that we know that those procedures are at least moderately effective and cost effective as well, it becomes a moral obligation to talk about it. Because otherwise you take an option away that a patient only has at the time the cataract surgery is being performed. I'm not aware that there is a legal obligation yet. That means I'm not aware that any colleague has ever been sued for not talking about that with the patient, but that's on a different page. But the moral obligation for me stands that I feel we have to talk about it with our patients. They may not take the chance and they may say like, well, I go with the cataract surgery alone and we can later do a glaucoma surgery if that's really necessary, and I'm fine with continuing my drops. But I would always bring up the discussion, and we have this informed patient concept nowadays, that we have to talk with the patient, we have to give them the options that we think are available, and we have to accept that the patient then makes their own or his or her decision what to proceed with.
No, I think we're in a similar situation in the UK at the moment, in that this specific question has not yet been tested in law. We have not yet had, as far as I'm aware, and as far as my medical legal barrister lawyer friends are aware, tested the question within ophthalmology specifically. Do you have a legal obligation to inform patients that this is available? But we do know from case law in the UK that if the majority of clinicians are of the view that this would be standard of care, and you don't offer it to someone, well, then you are on a pretty sticky wicket, as we say. You're on pretty thin ice. And in fact, we've recently surveyed the UK and Ireland Glaucoma Society, and I think it was over 95% of the respondents said that, in their opinion, there was an obligation to offer every glaucoma patient who might be eligible and might benefit. And in my hands, that's not pretty much anyone on drops. Inform them about the possibility and existence of MIGS devices, procedures at the time of cataract surgery, at the time of taking their consent, even if you don't yourself offer them. And if the patient wants them, then they should be referred on to somebody else. So although no one has yet tested this question in law, and it hasn't actually been judged upon, I think there's a pretty strong now UK legal case for saying that there is a legal obligation to offer it to anyone having cataract surgery who might benefit. Now, we can argue about who might benefit, but I think we'd all agree that that's a pretty broad group. So I think it's going to be interesting, you know, how that comes about. What's your advice in your two current environments, you know, US and Switzerland, about how you would advise colleagues who might not be glaucoma specialists? What would you say to them about what we should be doing for patients who have glaucoma at the time of cataract surgery?
The US system nowadays has incorporated training of mixed procedures as a mandatory requirement for all our residents. So the amount of surgeons, not only glaucoma specialists, but also the comprehensive cataract surgeons that we have, will in the future be able to some degree to do mixed procedures. Some of them may opt out not to do it, but my advice is always, like, as we talked about earlier, offer it to your patients. If the patient elects to do it and you're not comfortable doing those procedures, in these cases, refer the glaucoma patient to a glaucoma specialist or a colleague who is doing cataract and mixed procedures combined. But again, it all goes back to this ethical obligation that we feel like we want to offer a best available treatment to our patients. So if you don't do it alone, refer the patient back, and you can later take care of the patient again after the surgery, but don't take a chance a patient has once in a lifetime away from them.
Yes, I think one of the recommendations we had in the UK from this survey was that it's been published in the journal I, the Journal of the Royal College of Ophthalmology. And one of the recommendations we had in that report was that the majority of glaucoma specialists were of the opinion that the person making the decision to do the surgery should be the individual responsible for their long-term glaucoma care, even if that individual is not necessarily the person who carries out the procedure, because we all know that procedures such as an ELT, excimer laser trabeculoplasty with an Elios, is a very, very straightforward procedure to do with a very, very short learning curve. So I don't think you have to be a glaucoma specialist to be able to do a MIGS procedure, but I certainly think that you need to be a glaucoma specialist to judge whether or not it's appropriate for a particular given individual, looking at the whole course of their disease. Timothy, what's it like for you?
Yeah, I mean, in Switzerland, I think correct English is we were in a bit of a pickle with regards to reimbursement because mixed procedures, they fell out of the reimbursement by mandatory health insurance. And now, well, the principles that allow a procedure to be reimbursed, that's effectiveness, appropriateness, and economic viability. And for a while, mixed procedures were reimbursed, but then the regulators felt they were overdone for a bit. And so the current policy is that you can apply by the health insurer individually. And you need quite good evidence in order to convince the insurer that your patient is eligible for a reimbursement. So I think now the situation with regards to evidence-based surgery is quite a good one, but the amount of administrative work that it takes for each and every mixed patient or that qualifies for mixed surgery and actually consents to mixed surgery is quite extensive. So there is some work that is now being done in between the Swiss Ophthalmological Society and the regulators. And then hopefully there will be an agreement reached with regards to the mixed procedures on the long run. But you were asking about whether the procedure itself where it is taking place in the hands of glaucoma surgeons or non-glaucoma surgeons, and show that there is many highly qualified anterior segment surgeons in Switzerland who are not by definition glaucoma specialists, but who are very capable in doing the MIGS procedures. So I would agree to the point that in the end, the MIGS procedure, because it's quite straightforward, does not necessarily have to be done by a glaucoma surgeon. But it is an interesting idea worth pondering to say that in the end, the long-term treatment for glaucoma should be done by the same specialist in order to monitor progression and to see that you get optimal patient care.
Yeah, I think that's very much what we're moving towards across the board, actually. I mean, I think we're getting close to time here, and we should probably be thinking about wrapping up. Were there any takeaways that you wanted to just briefly give those who are listening about either the role of health economics, the role of MIGS, or more specifically about ELT and Elios? What do you want to wrap up with, Marc?
I think the health economic aspect that we get more and more data on for the different MIGS procedures kind of strengthens its place in the treatment of glaucoma. It's part of our armamentarium nowadays, and that's kind of nice to see. It's not only effective, but also cost effective. We talked about the factors that we feel like it should be part of the discussion when a patient undergoes surgery, that we offer that. And I personally feel very strongly about that part. We didn't talk about long-term data, but what for me is one of the main reasons why I like the ELT procedure with the Elios laser nowadays is that I actually had done this as my very first MIGS procedures, and we looked at also long-term data, and we found the procedure to be effective with data now providing that or supporting that for up to 8 years. And that's quite challenging for me to ignore. And I really like the idea of having a small, as you said, procedure with a quite steep learning curve, which still shows over at least 8 years success. And that's pretty impressive for considering that we don't do that much in the eye, and we kind of try to preserve the natural anatomy of the outflow system still without an implant.
Yeah. Timothy, anything you want to say?
Yeah, I think, well, on my side, I'm a huge fan of evidence. So, as we all are, what I would really emphasize is that I'm convinced that if something works well, it will prevail. And I think what is useful to have really to put the effort and to create randomized clinical prospective trials, potentially also including these new health economic metrics, whether that's our task or whether that's something that has to be done in sub-analysis after those prospective studies, that remains to be seen. But I think we need, on the one hand, nicely designed clinical prospective randomized trials, but also real-life evidence. So you were already mentioning that many non-glaucoma specialists, potentially also outside of clinics, perform the MIGS procedures. And I would be very interested to see the results of the community, not also in sterile clinical trials, but also data from outside of clinics, from outside of the trials. And to gather that, I think that's a big task, but that really shows the evidence how MIGS perform not only inside our trials but also outside of the hospitals.
Yes, I think it's going to be very interesting to see some of that large data, real world evidence. So thanks very much, guys. That's been great, and thank you very much for giving up the time and giving our listeners the opportunity to hear your thoughts on that. I think they will agree that health economics is a very important part of building up a business case towards justifying the introduction of new technologies, new devices, and new procedures. and hopefully this will go some way to helping them towards that. So thank you very much, and I look forward to seeing you at a meeting around the world sometime soon.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more details on this episode and to read the show notes, visit eliosvision.com/OUS/podcast. To learn more about Elios and contact us, click the link in the description. The Elios system Bausch & Lomb is manufactured by MLase GmbH and by WEINERT Fibre Optics GmbH. Elios is CE marked for use in adult patients with glaucoma and is currently under investigational use in the US as part of an ongoing IDE study by the FDA. The ExTra 2 Laser Class 4 has the brand name Elios. The ExTra 2 is equivalent to ExTra and AIDA devices. Please refer to the full disclaimer in the show notes.